Today we are going to talk about the diaphragmatic hernias. They could be congenital and acquired, seen in the adult life, but most of them are congenital. So we'll talk initially about congenital to get some idea. They can occur in 2,000 to 1 in 2,000 to 5,000 live birth, and 95% are posterolateral defects like Bogdack, Morgagni's, and pars sternalis hernias are rare, and 10 to 50% have associated. So the diaphragmatic development begins from fourth week, and the anterior central tandem septum transversum fourth week forms the inferior portion of the pericardial cavity and defines the rudimentary pleuroperitoneal membrane and dorsolateral portion and the closure of the pleuroperitoneal canals and the formation of the pleuroperitoneal membrane and dorsal crura and dorsal esophageal mesentery and muscularization of the diaphragm from the thoracic intercostal muscle group and the posthepatic mesenchyme. The failure of the closure of the pleuroperitoneal canal 9 to 10th week and the posterolateral and the lumbocostal trigone weak area by the Bogdack can. And the pathophysiology, the combination of events, physical compression, pulmonary hyperplasia, bilateral, ipsilateral, and contralateral, and is correctable. And and the pulmonary hypertension, potentially reversible, lack of pulmonary arterioles, increased thickness of the muscles, and abnormally high vascular reactivity of the vessels and left to right shunt. And prenatally, ultrasound can diagnose 50%, and 50% are normal, and there could be polyhydramnios absent, intrathoracic stomach bubble, or mediastinal cardiac shift. And we can do a fetal MRI to diagnose this condition if there is a strong suspicion or a further confirmation. So diagnosis postnatal radiography in first 24 hours shows scaphoid abdomen. After 24 hours, there is vomiting, cough, cyanosis, gastric outlet obstruction, herniation of the liver, spleen, and prognostic indicators are herniated organs, including liver, lung to head ratio, and other associated anomalies. Prenatal diagnosis, one need to check the associated anomalies, plan for delivery in the tertiary perinatal center, and perinatal therapies and termination treatment after delivery. Investigations, one need to do the arterial blood gases, chromosome studies, serum electrolytes, echo, renal ultrasonography, and pulse oximetry. Spontaneous vaginal delivery close to the term and initial resuscitation should be carried out. ET tube, NG tube, fluid status, inotropic support, and delayed surgery should be offered. Mechanical ventilation and paralysis with sedation, arterial venous access, IV antibiotics, NG tube, inotropic support, temperature maintenance, and surfactant could be offered along with tolazolene. Ventilation should be optimized to avoid barotrauma. Surgical repairs, there are various types of surgical repairs that can be offered. Open abdominal or thoracic approach and reconstructive option using the prenatal fascia and skin closure creating a ventral defect could be used. Long-term outcome, patient can have gastroesophageal reflux disease, neurological outcomes, chronic lung disease, growth issues, and chest wall deformities. Newer advances in uterosurgical repair, tracheal ligation occlusion, fetal procedure, and ventilation strategies of various advancement, including the ECMO, lung transplantation, growth factors could also be used. Now, the few things about the adult hernias, the foramen Morgagni occurs through the anterior retrosternal diaphragmatic defect, and the left-sided defect is less likely to result in herniation than on the right side due to the overlying pericardium. For this reason, 90% of these hernias occurs on the right side, 8% are bilateral, and 2% are on the left side. They occur more commonly in the women, and they are more frequently diagnosed in the obese patient than in those with the normal or below average weight. The surgical repair can be accompanied by either transthoracic or transabdominal approach using either open or minimally invasive technique. The hernial sac is generally encountered and should be excised A small defect into the space of Larry can be closed primarily, while the large defects may require a prosthetic patch, and the result of the surgical repair are excellent, with the reports of recurrence being rare. Hope you have enjoyed. If you have any questions, you can write in the comments, and we can try to address in the next videos. Thank you.